Okay, our next speaker is Dr. Navin Pinto. Dr. Pinto is a professor at University of Colorado and an attending at Colorado Children's, and has strong ties to New Orleans. He was actually born here, which is kind of awesome, and he's been at CAGLA now for 3 years in a row. He and I did fellowship together, which for him was really tough. I mean, imagine doing fellowship with somebody with so much style. It was tough for him. But he managed to muggle through that and is now one of the country's experts on neuroblastoma, which he's going to talk about today.
Great. So I'm going to try and do a rapid-fire overview of neuroblastoma and the landscape and essentially how we got to our current standards of care through the history of clinical trials. So this is a slide that I borrowed from Bob and my mentor from the University of Chicago, Sue Cohn, and really drew me to neuroblastoma was its really interesting clinical and biologic heterogeneity. On the far left of the screen, we have a child that had a large adrenal mass with a liver chock-a-block full of tumor, and based on what we knew of the age of presentation and the biology of the tumor, this patient was observed and had spontaneous regression of their tumor without any treatment. That's the formerly known 4S, or now known as MS stage of neuroblastoma. In the middle is a patient who had a very similar presentation, a very large infiltrative primary tumor and some metastatic disease. But again, based on the age of presentation and the biology of the biopsied tumor, we knew that this patient only needed a whiff of chemotherapy. This patient received, I believe, 4 cycles of outpatient chemotherapy and did excellent and had residual tumor that was left in their body after 4 cycles, but we knew that that tumor would not pose any future threats. And then, what I'll focus on is high-risk neuroblastoma, which is the challenge. This is a patient who's photographed at presentation with the classic raccoon eye presentation of orbital metastatic disease and very ill with widespread metastatic disease. And despite a very aggressive kitchen sink approach, which I'll get into, still only about 50% of patients in this category survive. So this is just sort of general boards information. Neuroblastoma is the most common extracranial solid tumor, or the third most common tumor that we see in pediatrics behind ALL and brain tumors. I included this relatively busy slide, just that neuroblastoma can present in a variety of different ways, most commonly with abdominal swelling and pain, but it's one of the few tumors that also has paraneoplastic syndromes, which are very interesting. So patients can present with opsoclonus myoclonus ataxia syndrome, which is an autoimmune condition where we think that the B cells are trying to control the patient's tumor and cross-react with the patient's neurons. This can be a very challenging disease to treat, and we're just now starting to understand some of the biology. And then I've only seen this a couple of times. Most recently, a month ago, a patient with intractable diarrhea as their tumor secretes a vasoactive intestinal peptide. The staging system is used to be a straightforward 1 through 4 system with the 4S pattern thrown in for good measure. And we've simplified things now to either localized or L if it infiltrates and wraps around organs or blood vessels, it's L2. M is for metastatic, and MS is the old 4S pattern. We're also starting to understand the biology now of why this wide clinical behavior and spontaneous regression versus metastatic disease that either behaves itself or doesn't. And really it boils down to telomere maintenance. So high-risk tumors tend to have a telomere maintenance mechanism, a mechanism to maintain the length of their telomeres through subsequent cell divisions. Normal cells do not have that, and so non-high-risk tumors do not have a telomere maintenance mechanism, and as they divide, their telomeres get shorter and shorter, and there's a critical point when your telomeres are short enough that the cells either senesce or die. And so High-risk tumors are sort of immortal because they have a way to maintain the length of their telomeres and therefore are very resistant to death. We also know that very rarely neuroblastoma can run in families. There are really two major categories where this happens, both syndromic and non-syndromic family history. So non-syndromic, those patients don't have any other symptoms besides a history of neuroblastoma. These families tend to have ALK mutations. This was shown by Yael Mosé at CHOP in the mid-2000s. Then the syndromic form, which I didn't show here, is something called central congenital hypoventilation syndrome, also known as Ondine's curse. That is a germline mutation in FOX2B. These patients have, as the syndrome suggests, have hypoventilation, usually are trach vent dependent, and stay in the hospital for long periods of time, mostly due to their respiratory issues. So there's a whole host of prognostic markers that we have learned about in neuroblastoma, and I've highlighted really in red that we're still using features that we discovered in the 70s and 80s to risk stratify patients. And all of this other long list of genomic aberrations that we found subsequently haven't improved our power to prognosticate patients above and beyond what very astute clinicians learned almost 40 or 50 years ago. Again, another busy slide. This is taken from Meredith Irwin's paper in the JCO a couple of years ago, which really breaks down how we risk stratify neuroblastoma patients. So it's unfortunately too small to show here. I apologize, but we take the patient's stage, their age. The middle portion here are essentially genomic risk factors like MICAN amplification, and out spits your risk group, and therefore most people, like Bob mentioned, sort of follow the COG approach to treating these tumors. So about half of patients with newly diagnosed neuroblastoma have high-risk disease, and you can see the breakdown of the other risk groups. And again, this is sort of the really stark differences in survival. So low-risk patients essentially need no therapy, either surgery alone or observation. Intermediate-risk patients usually receive very low-intensity outpatient chemotherapy, 2 to 8 cycles, and have excellent outcomes with very de-intensified therapy. And this is an old slide now taken from 2001, so the high-risk survival is skewed downwards to what it is today, but does sort of illustrate the stark contrast in outcomes between these groups. Luckily, we're a little bit closer to the high 50s now, so this curve should really be drawn here. So really, the goal of neuroblastoma treatment is to tailor therapy according to the patient's risk. And I'm going to run through several clinical trials that have been done over the last 30 years, mostly through the Children's Oncology Group and its predecessors, to help the audience understand how we got to where we're at today. The first is influenced our understanding of low-risk neuroblastoma. So this was a POG study, 9641, done in the late 1990s and early 2000s. Essentially, we used to treat all neuroblastoma patients the same with relatively intensive chemotherapy, and started to learn that some of these clinical and biologic risk factors may predict good versus bad actors. And so based on our understanding of the biology at the time, we said that patients with localized tumors who were asymptomatic and didn't have any of the adverse biologic features like MICAN amplification may be successfully treated with surgery alone. And so asymptomatic patients had that, and symptomatic patients who had organ compression, spinal cord compression, severe pain, were treated with 2 or 4, up to 4 cycles of low-intensity chemotherapy to shrink the tumor, followed by a surgery. So these are the outcomes for that trial. As you can see, the overall survival is excellent. Close to 100% of patients survived with this approach. And the event-free survival, although it looks much lower, I'll just highlight that the graph starts at 60%. So over 90% of patients did not have their tumor progress or recur with this approach. So then to sort of further this approach, there was an observational study that told us that maybe even surgery was too intensive of a treatment for a subset of patients. And this was a study that had an initial intention, and we learned a different outcome. So the initial intention of a study was that we know that many neuroblastomas secrete HVA and VMA. These are catecholamine metabolites in the urine. And so people smart investigators said, well, can we newborn screen babies for neuroblastoma by testing their urine? And could we detect localized tumors before they metastasize and therefore prevent patients from developing high-risk neuroblastoma? So these were newborn screening programs that happened in Japan and French Canada, where in both subsets, they essentially doubled the rate of neuroblastoma in those communities, but there was no decrease in incidence of mortality. And that all of the tumors that came up on screening and then were resected had favorable biology, didn't have MYC amplification, didn't have any of the adverse biologic features. And so the conclusion of this screening study was that tumors diagnosed in infants are unlikely to progress to high-risk neuroblastoma. And many of these, because we doubled the rate of incidence, were clinically undetectable and therefore likely spontaneously regress. So this shifted our understanding of low-risk neuroblastoma and that patients may be successfully observed without any interventions at all. So in the early days of the Children's Oncology Group, AMBL00P2 performed in the early 2000s, took patients less than 6 months of age with a small localized tumor limited to the adrenal gland and did nothing. They tested positive for catecholamine metabolite increase. They had a tumor in a location that was most likely to be a neuroblastoma, but they didn't get a biopsy. They didn't have any intervention. And this is the result of that study looking at resection-free survival. So what was your probability of staying on the study without needing to go to surgery? And over 80% of patients were successfully observed in this cohort. Now, and if you really cut the data, there were many patients that the actual resection-free survival was probably higher than this because many physicians got nervous in the early days of this, and many parents got nervous. And subsequent studies have shown it's probably in the mid-90s of patients that can be successfully observed in this cohort. The COG had a follow-up study which broadened the enrollment criteria for this, and we're anxiously awaiting those results. But we just learned, I was involved in this study and just learned that the last patient finished their observation period, so we can start analyzing the data very soon. And we anticipate that even in a wider cohort of young patients with localized tumors that they can be successfully observed. So we'll jump to intermediate risk. Again, this is trying to tailor the amount of treatment needed to advance a good outcome. And the first study of this was a Children's Cancer Group, or CCG study, of infants and children with intermediate risk neuroblastoma, again, performed in the late 90s. This tailored the amount of chemotherapy based on the patient's tumor biology. These were all MYC non-amplified tumors by definition, but patients with favorable histology and hyperdiploid tumors got less chemotherapy than those with unfavorable histology or diploid tumors. So 4 versus 8 cycles of chemotherapy dictated by the tumor's biology. And again, another excellent survival curve from that approach. Over 90% of patients did not experience a relapse or progression, and almost 100% of patients survived with this approach. In fact, as I dug into the data, there were at least one patient that died of a non-neuroblastoma cause on this curve that died in an automobile accident. And so the curves are pretty darn close to 100%. So that led to the predecessor intermediate risk study where, again, we used as much biology as we knew possible for neuroblastoma, things like ploidy, histology, and any segmental chromosomal aberrations to really dictate the amount of therapy. A very busy slide here just showing the sort of choose your own adventure nature of this non-high-risk study, but giving patients as few as 2 cycles of chemotherapy and as many as 8, depending on their tumor biology. And again, you can see here that almost universally these patients did quite well with overall survival is well above 80%. The patients at the lowest curve are those with the most aggressive types of neuroblastoma metastatic disease with unfavorable genomic features. Again, this curve is a little worrisome, and again, we're trying to address ways to better treat these patients in future clinical trials. So I'll dive into high-risk neuroblastoma because this really exists as the challenge. Our current treatment overview is really broken down into 3 major phases. Induction chemotherapy, where we give traditional cytotoxic chemotherapies, an attempt to surgically resect the primary tumor, and a collection of the patient's own peripheral blood stem cells to be used in the next phase of therapy, consolidation, where at least in the children's oncology group, the standard of care has emerged to do 2 tandem cycles of high-dose chemotherapy followed by autologous stem cell infusions. Radiation therapy is used to the primary tumor and any metastatic sites that persist. And then neuroblastoma was one of the first pediatric tumors to use immunotherapy to achieve better outcomes, and I'll show some of that data. So again, we've made progress. The curve that I showed comparing non-high-risk and high-risk outcomes, again, was showing outcomes sort of in the 40% from the late 90s, early 2000s. And our curves now are getting into close to the 60% range for 3-year event-free survival. So not ideal, and there's a lot of work to do, but these gradual intensifications of therapy on cooperative group studies have led to improvements in outcome. I'll highlight my colleague Julie Park from Seattle Children's, now the Director of Oncology at St. Jude, who led one of the most seminal high-risk neuroblastoma studies that informed standard of care, and this was ANBL 0532, a study that randomized patients who had responded to induction chemotherapy, 6 cycles of induction, to get either 1 autologous transplant with a CEM conditioning regimen or tandem transplant with 2 cycles of high-intensity chemotherapy followed by an autologous stem cell infusion. All patients went on to get radiation therapy to their primary tumor, and there was a concurrent study that I'll highlight that was evaluating this novel immunotherapy, dinutuximab, with cytokines that patients could also enroll on. So Julie's data was presented at ASCO in 2016 and then published in JAMA the next year, and showed that there was a statistically significant reduction in relapse, or 3-year event-free survival with tandem transplant. There was not a significant change in overall survival between single versus tandem, which is sort of the main critique, but this change in event-free survival did lead to many centers adopting tandem transplant as the standard of care. There were some subset analyses because immunotherapy wasn't routinely used for every single patient that was on Dr. Park's study, that if you bisect the data further and look at patients who got tandem plus post-transplant dinutuximab, that there was a statistically significant difference in event-free and overall survival in those cohorts. again, this is the data that led to dinutuximab being approved by the FDA. This was randomizing patients after completion of consolidation and radiation therapy to either get a differentiating agent, cis-retinoic acid or Accutane, with or without the anti-GD2 antibody, now known as dinutuximab. This was given with two different cytokines, either GM-CSF or IL-2, to stimulate an innate immune response. And the sort of proposed mechanisms of action of dinutuximab were that it both had complement-dependent cytotoxicity, that antibody-bound tumor cells would activate the complement cascade, leading to the membrane attack complex formation and tumor lysis. And there was also a cellular component that these antibody-tagged tumor cells would trigger NK cells to lyse these target cells, and that the proposed mechanism of IL-2 and GM-CSF was to increase numbers of these effector cells. So the results from that study, again, showed an improvement for those patients who got the anti-GD2 antibody. This is, again, event-free, not overall survival, but a pretty dramatic increase in event-free survival, which, again, led to really the first pediatric only approval of an immunotherapy. And again, this is still a drug that's really only used in neuroblastoma. So again, a whirlwind tour of data that has gotten us to tandem transplant, post-transplant dinutuximab being the standard of care for high-risk patients, and using patients' biology to dictate how much therapy, if any, in the non-high-risk setting. So these are just some bullets from the high-risk neuroblastoma studies I highlighted, that somewhat better outcomes are observed when consolidation is intensified with tandem transplant. I didn't show this data, but a question I get asked from a lot of parents when we're talking about giving back a patient with metastatic disease their own stem cells is, aren't you just giving back my child their neuroblastoma? And so there was a study where peripheral blood stem cells were purged of any residual neuroblastoma cells in an early COG study, and that did not show any impact on outcome. So we do not think that the neuroblastoma cells do well in the cryopreservation environment, and that very few neuroblastoma cells actually are circulating at the time of peripheral blood stem cell collection. We know that post-consolidation therapy with both Accutane and dinutuximab is effective, but all of these studies have essentially been adding more and more and more to high risk because our outcomes aren't great, and that we know that this intensification of therapy over time has led to significant toxicities, many late effects, and yet 50 to 60% of patients still relapse. So just wanted to highlight a few areas where we're going. This is a cartoon from a publication I was involved in, sort of highlighting some of the cellular pathways that are potential vulnerabilities in neuroblastoma. There are cell surface proteins like GD2, which is what dinutuximab targets, and L1-CAM that may be suitable targets for things like CAR T cells. The group in Rome at Bambino Gesù did a CAR T cell study for relapsed neuroblastoma patients targeting GD2, and in a very select group of patients with relatively low disease burden but relapsed disease, reported a 60-some% objective response rate to those CAR T cells. Theranostics are a hot topic in adult oncology like prostate cancer, and neuroblastoma was also one of the very first tumors to be treated with radio-labeled theranostics like MIBG. We have all sorts of cellular pathways, anti-angiogenic inhibitors, tyrosine kinase inhibitors that are also being evaluated. But I wanted to highlight MIBG therapy because that's a therapy that our center offers and isn't offered universally. So MIBG is used both in diagnostic. We do MIBG scans. This is a cartoon of norepinephrine And you can see the similarities for MIBG, which is meta-iodobenzylguanidine, an iodine-labeled molecule that can be taken up by the norepinephrine transporter in neuroblastoma cells and helps us in diagnostic scans to look for sites of metastatic disease. This patient with relatively oligometastatic disease, meaning just localized tumors with a few sites of metastatic disease, and this patient with much more extensive disease throughout most of the bones and bone marrow. Administering I-131 MIBG as a theranostic is challenging in that it makes the patient radioactive. So the patient who gets a dose of MIBG therapy has to be in isolation. And with most of our neuroblastoma patients being toddler age, this can be very challenging. And so the patient is emitting relatively high doses of radiation from their body. And so we have to be very careful when giving this drug. We have to use a Geiger counter on our clothes and shoes as we enter and exit the room, track our radiation doses very diligently to ensure we're not exposed to radiation. And then this is just a picture of the drywall, beneath the drywall in the MIBG room, which is a lead-lined room. So these are lead bricks lining the room to prevent exposure to radiation therapy for those outside of the room. So MIBG therapy was very active, or at one of the most active agents we saw in relapse. About 30% of patients with relapsed neuroblastoma will respond to MIBG therapy. And based on that encouraging response, the COG ran a trial. I apologize for how busy it is, but essentially the question they were asking on this trial was, could MIBG therapy be incorporated into upfront treatment of high-risk neuroblastoma patients and improve outcomes? I don't have the results of that study, unfortunately. The study was closed about 3 years ago, and I have been told that the results will come in October of this year. So we'll soon learn whether MIBG therapy should be considered for everyone if it improves outcomes. Our current high-risk trial is looking at dinutuximab as an addition to induction chemotherapy. So I mentioned that dinutuximab given after transplant improves outcomes. There was some data generated by St. Jude that if you gave dinutuximab with induction chemotherapy, you improved your end induction responses, and that at least in the hands of St. Jude, the overall and 3-year event-free and overall survival were improved to other historical studies. So that generated a lot of enthusiasm, and we're now randomizing patients 1-to-1 to receive either our standard 5 cycles of induction with just chemotherapy alone, or chemotherapy plus dinutuximab. The study we want to sort of stratify patients by their known biology, like MYC-N, presence of metastatic disease, and so everyone gets a single cycle of standard cytotoxic chemotherapy, and then once all the biology information is back, we randomize patients and try and balance the randomized arms. Everyone then goes on to get tandem transplant and post-consolidation dinutuximab as is the standard. So we know that, again, we've intensified therapy to lead to these superior outcomes, and that definitely comes at a cost. Essentially, every organ in a neuroblastoma patient's body, should they survive, has been affected by the intensive treatment. The most obvious are ototoxicity or hearing loss induced by platinum compounds. But really, like I mentioned, every organ system seems to be affected. Endocrine dysfunction and infertility is another really prominent feature. This is a patient standing amongst her peers, who you can see is quite delayed in both her height and in her sexual maturation. And again, this is a publication from a colleague from the University of Chicago, Mark Applebaum, that showed that the rates of secondary malignancies, if you look by era, that in the most recent era, the graph of secondary malignancies seems to be escalating compared to historical controls, and that you could march this out, and that, 20 to 30 years from the current era that we may see secondary malignancy rates as high as 5%. Relapse neuroblastoma, just very quickly. I'm over time, I apologize. Really, our current standard care is to use dinutuximab with chemotherapy. So this was a randomized study where patients got irinotecan and temozolomide and either temsirolimus, which was an mTOR inhibitor, which had some in vivo activity in model systems against neuroblastoma versus dinutuximab. And the results were pretty dramatic that dinutuximab improved outcomes. So this has become our sort of de facto standard of care for relapse disease. Okay, I'm over time, so thank you very much. I'm happy to take questions or move on to the next topic. Bob.
Well, I hate the results of OVAC-3 too.
Yeah.
I really was hoping that we could more too. And how kind of hard to recognize some of the data at MSK where they don't often or didn't transplants.
Yeah.
And with really good outcomes. And so.
Yeah, this is an eternal debate in the field. I didn't have time to include this, but we're already working on the next phase 3 study in neuroblastoma, which I'm going to lead with Jenny Foster from Texas Children's. And that is actually based on this relapse data of chemoimmunotherapy being very active. We're actually going to randomize patients to chemoimmunotherapy consolidation, 6 cycles of reno, tem, dinutuximab, versus tandem transplant. So it's transplant-free approach, trying to mimic the MSK approach. I think MSK's data is very exciting, and they do treat many of their patients without transplant, but it's so personalized at the level of the patient that it's really hard to draw any conclusions about how to do that, in a wider cooperative setting. So this was our attempt to try and see if a transplant-free approach is feasible. Yeah.
Second question is, I may be making this up. I thought I recently read that there's a trial that's about to start using a p53 activator in neuroblastoma early phase. Is that at the advanced? Have you seen that?
That is not coming through the NANT consortium. I mean, there's a lot of interest in p53 activators, and certainly patients who acquire p53 mutations or have them de novo have really bad outcomes. So I'm not sure.
I came across this typically for me, and I saw that it's about to be trialed, I think.
Yeah.
I don't remember though where.
Yeah, a lot of that work came out of Utah from Josh Schiffman. But I don't. So I'll have to get back to you. I'm not sure where that's. Yeah. 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 Okay. Thank you, everyone. Appreciate it.